All right, welcome everyone, and thank you for joining us to our webinar tonight, Acne and Psoriasis, Quicker Clearance and Better Patient Outcomes with a 650 microsecond device, presented by Mark Nestor, MD, PhD, and Julie Santos PA-C. I would like to introduce our presenters for tonight. Mark S. Nestor, MD, PhD, serves as Director of the Center for Clinical and Cosmetic Research and the Center for Cosmetic Enhancement in Aventura, Florida. He is a voluntary associate professor in the Department of Dermatology and Cutaneous Surgery and the Department of Surgery, Division of Plastic Surgery at the University of Miami, Miller School of Medicine. Dr. Nestor is recognized as a world expert in clinical research in most areas of dermatology and aesthetics, including acne, psoriasis, atopic dermatitis, and skin cancer, light therapies to treat skin disease, cutaneous laser surgery, photodynamic therapy, and radiation therapy. His aesthetic expertise includes lasers, RF, other devices, and the use of fillers and toxins. Dr. Nestor has been an Aerolase user since 2016 and is a clinical investigator for Aerolase acne and psoriasis research. Julie Santos is a certified physician's assistant with Skin and Cancer Associates Dermatology, the Center for Cosmetic Enhancement and Center for Clinical and Cosmetic Research in Aventura, Florida. For the past 19 years, under the direction of Mark S. Nestor, she has performed a multitude of both clinical, dermatologic, and cosmetic enhancement procedures, which include laser therapies, as well as assist in overseeing the clinical and research staff. Ms. Santos has been an Aerolase user since 2016 and is a clinical investigator for Aerolase acne and psoriasis research. So with that, I will turn it over to Dr. Nestor.
Good evening. So tonight we're going to really touch on the use of 650 microsecond foundation therapy for both acne and psoriasis. And it's really a pleasure to talk about this device because I've been using lasers for 25 years, both aesthetically and clinically, and we've had just such a wonderful response from our patients with a variety of different conditions and needs with this platform. We've spent a lot of time looking at treatment algorithms for both acne and psoriasis and are in the middle of blinded clinical studies for publication and for efficacy. So we'll start out with acne and with both the clinical background and the use of this device for acne. So we know that acne is very, very prevalent. The epidemiology and social impact are very significant, both from the aspect of young adults, where it affects at one point up to 85% of individuals aged 12 to 25, as well as adult women, 37% age 25 to 50, and about 25% of adult males 25 to 50 as well. Aside from the clinical aspect and certainly the scarring that presents, negative sequelae include social withdrawal, anxiety and depression, and really being very self-conscious regarding the patient's skin. As providers, we look for acne treatments to be safe, effective, and tolerable. And whatever we use, it should really look to satisfy these three categories. So let's look a little bit at the etiology of acne. Acne starts probably with a combination of the first two things. Certainly, excess sebum is the basis of this. And as we know, excess sebum comes from two aspects in acne, a genetic predisposition as well as hormones. And that's certainly the key aspect of why it appears during early adolescence. The second is known very well, which is parafollicular inflammation. This is probably one of the hallmarks of early acne, and it really shows early on with formation of comedones. We have follicular hyperkeratinization, which causes clogging in a number of aspects. And there's also colonization of P. acnes. And there's a very significant ramp up that you can see in these depictions here of the issue of sebum formation, with trapped sebum, inflammation, P. acnes colonization, inflammation, whether it be papules, pustules, or cysts from that perspective. So the current treatment algorithms for acne are certainly can be complicated. Oftentimes they have limited efficacy. It depends on the patient and the type of condition they're presenting with. Mild acne, generally we use topical retinoids for comedonal acne. And alternative to that may be salicylic acid, azelaic acid, and sometimes in the aspect of washes as well. Mild mixed papular, pustular, comedonal acne, again, topical retinoids. Physicians are getting away from using antibiotics. The topical antimicrobial is probably more BPO in this case, certainly topical retinoids or azelaic acid as well. And the maintenance for this is very often topical retinoids. When you get into moderate acne, there's a mixed choice that many individuals go to oral antibiotics. Doxycycline is the primary one, but I think that the main acne group is trying, for a number of reasons, to get away from the use of oral antibiotic because of antibiotic-resistant bacteria that is forming across not just acne patients, but all patients because of the overuse of antibiotics. So this is something that is phasing out very quickly. Topical retinoids, topical BPO is certainly used. And in women, very often we use oral anti-androgen, spironolactone, and other agents as well. For nodular acne, more moderate towards severe, combination therapies are often used. Oral antibiotics, at least for present time, topical retinoids. Isotretinoin is used in this population either in combination, and certainly in women, very, very often there is an oral anti-androgen in addition to this. And certainly in nodular severe acne, isotretinoin has certainly over the years been the drug of choice. There are certainly other alternatives. Not everybody can tolerate that as well. And as you see in women, the anti-androgens are also effective. Maintenance therapy is always probably use of topical retinoids and BPO, but for many individuals, the orals are necessary in more severe cases. Now, we know that compliance is a major issue for success in acne, and this is just a depiction of the difficulty in keeping our patients compliant with taking medications. We know this not just for oral medications, but also for topicals. And you can see this study that showed that just 25 to 30% the prescriptions are taken properly, even less are refilled as prescribed and taken. And this is certainly a challenge for our acne patients. And of course, we know that getting prescriptions filled and getting them paid for is a royal pain in the neck, not just for our patients, but for our offices and our staff. Getting prescriptions approved is a full-time job for a lot of staff members. But more than that, patients also have much more out-of-pocket costs for a variety of prescriptions, and this is just showing a variety of different prescriptions and actually the prices in the U.S., and much of the cost is borne now by the patient, and this also cuts down on compliance. Additionally, as we know, acne treatments often take significant time to show results, and significant improvement can take 6 to 12 weeks as well. So the benefit of NeoClear in this case offers treatment that addresses the key aspects of acne in one modality: sebum production, inflammation, and P. acnes. And the idea here is that the treatment addresses by heating the sebaceous gland. There is a reduction in sebum output. There is a change in coagulation of some of the capillaries, and this combination tends to suppress inflammation. The P. acnes are also destroyed, and the colonization from that aspect is reduced. And all this together really creates the perfect storm for reducing long-term the key building blocks of acne. So in essence, because we know that isotretinoin works through reduction of the sebaceous gland, the effect on the patient with acne is very similar of the NeoClear and isotretinoin, certainly without the issues associated with isotretinoin from monthly blood work, worry about liver damage and increased blood lipids, pregnancy, and certainly our staff. We know the difficulty in doing the paperwork as well as filling out all the questionnaires for use of isotretinoin. Out-of-pocket cost, again, for patients can exceed significant amounts of money, up to $1,000. So the idea here is, again, the 3 steps of decreasing sebum production by targeting sebaceous gland, suppressing inflammation, and killing the P. acnes with one modality. The beauty of 650 microsecond technology is that, number one, having a 1064 YAG laser has a very significant ability to have good penetration to the areas of the skin, including the sebaceous glands that we need the most. That's number one. The difference, though, with this unique technology is that you get a very high fluence in a short period of time, which occurs below any burning threshold, and you're able to treat structures deep without collateral damage. And that's really what's unique about this pulse width in combination with 1064. That really sets it apart. So there is no real downtime with it, and really it is very comfortable for the patient. It's not something that the patient feels pain because the pulse width is below this aspect of treatment discomfort. And because of this, and because of the technology and the issue of where it treats with the sebaceous gland, it appears, and we have seen it have significant effectiveness on the entire spectrum of comedonal, papulopustular, and nodular cystic acne, from mild to severe. And that's really one of the benefits of the technology. The other thing that can happen and that we see is that we get very quick clearing of results because of its action, both quickly on the acnes as well as on the decreased sebum production. We see results occurring very often within the first 2 weeks of treatment, and quickly gaining speed thereafter, whereas RX treatments take a lot longer to work. And here are some examples. You can see here very, very nice clearance. before and after 2 months with 4 treatments. One of the things that we see, and you'll see this on a couple of the pictures going forward, is in addition to quick clearance, what we also tend to see is longevity of results. And again, I think that is because of the action on the sebaceous gland, which decreases sebum production long term. So this is one of my patients here. You have a patient of Dr. David Goldberg's here, 3 months after 5 treatments. And our standard is 4 treatments. And this is a severe patient here, 13 months after 5 treatments, one of Michael Gold's patients as well. So you can see the spectrum of treatment here significantly. This is before and after 3 treatments, Kevin Pinsky. You can see that as well. And here's another patient showing a beautiful result before and after 3 treatments with out-of-spade skin care. The beauty also of this is that because it's a 1064 YAG laser and because of 650 microsecond, it's safe and tolerable with any skin type. And this is our definite go-to with African American patients who tend to have post-inflammatory hyperpigmentation, and we've had excellent results. And here's 3 treatments courtesy of Michelle Henry, showing Fitzpatrick type 6 African American patient. Again, another one, another patient showing significant reduction. Now, the nice thing here, and you can kind of see it here as well, is because we're also affecting the small blood vessels, the amount of redness and microinflammation in blood vessels and telangiectasies also is reduced. So the question then becomes how difficult it is to offer and have patients accept NeoClear. And what we found is that patients are really very happy to look at alternatives, especially something that has no side effects really and that is painless. That is something that not only patients but family members, mothers, fathers are very, very open to look at and try. The issue of the irritation of topicals, of side effects from oral antibiotics as well as isotretinoin really prods a lot of our patients and their family members to look for alternatives very quickly. So this is an example of patients who are looking for treatment of acne. Some do it right away. Some think about it, may try other things. And ultimately, a great number of them are open and sign up for NeoClear treatments. So the other thing, obviously, is that instead of going in the pockets of pharmaceutical companies, patients are certainly happy to pay for this. It varies across the country. We generally package it in our clinic because our patients should be on a regimen of 4 treatments. We charge $2,500 for 4 treatments. It varies in different parts of the country. However, and I think the key issue here is in addition to happy patients, it adds significant revenue, cash revenue in the practice. So I'll stop there for a second. That's acne. We can take up questions at the end for everything. And I'll switch gears a little bit for psoriasis. And this has actually been a wonderful addition to our clinical armamentarium because of its efficacy in psoriasis, and more than that, because it is reimbursed under almost all insurance companies. So not only where acne is self-pay from that perspective, because there really aren't any codes for acne, for psoriasis, there are CPT codes that are available, and I'll discuss that in a little while. So psoriasis affects up to 11, 12%, if not more, of adults, about 1.5% of children, two peaks between 30 and 40 and 50 and 70. Certainly, there are a lot of different sequelae associated with psoriasis, concern, depression, embarrassment, feeling of unattractiveness, and itchiness, significant morbidity just in terms of having the disease itself. Again, same idea. What do we want? We want safety, efficacy, and tolerability in our treatments for psoriasis. Pathogenesis of psoriasis is fairly well known at this time. Activation of T cells, pro-inflammatory cytokines causing inflammation, increased proliferation of keratinocytes, getting scale from sloughing, and thickening of the plaques as well, because the cells are mature and they don't fully slough off. There's also a significant increase in blood vessels that occurs within the radioridges of the epidermis and the dermis. So we have a number of different treatments for psoriasis. We have topicals, we have pharmaceuticals, and we have biologics, and then certainly we have light treatment and other treatments as well. Each one has its own issue associated with treatment, and I'll spend a little time going through this. Certainly biologics have changed the way, especially we treat severe psoriasis. What we should remember is that severe psoriasis or moderate to severe psoriasis only occurs in less than 10% or so of individuals with psoriasis. It's certainly not the common majority of people with psoriasis. The majority have limited disease, although it still can be of great concern to them. Biologics work incredibly well. However, they are very, very expensive. They certainly have immunosuppression side effects. It's also incredibly difficult to get things through insurance very often. They have to show failure of other therapies, and certainly patients with infections and TB or TB tests that are positive can be excluded from treatment. Traditional light therapies include certainly ultraviolet B and PUVA, but more recently the excimer laser. The nice thing about the excimer laser is that there are CPT codes, and I'll go through those in a little while, that have to do with laser therapy in general. Practitioners in most cases have the excimer laser put in by company, Strata, and they pay the company based on cars per pulse used. Patients come in once, usually twice or three times a week, up to 12 weeks. And because it's light therapy, there's redness, blistering, itchiness, burning sensation, and you can get an increased pigmentation. The Aerolase treatment addresses the inflammation as well as affecting the larger vessels feeding the plaque. So the laser light itself at this wavelength and with the aspect of 650 millisecond pulse suppresses inflammation and decreases the blood vessels associated with these plaques. Again, very similar as we talked about before, a very unique technology allows this to be painless, have a deep penetration of 1064 without collateral damage as well because of the unique 650 microsecond technology. So how do we compare it to others? Well, for very limited disease, we often use topical steroids. They reduce inflammation and have local immunosuppression. Certainly overuse can lead to atrophy, and we often get tachyphylaxis. And this as opposed to the 650 microsecond technology, which really coagulates the blood vessels and suppresses inflammation. And it also offers really side effect free treatment. That what we see is the rapidity and how quickly this works much faster than with eczema, and that's really what we're doing our study to document something we've seen over the last couple of years in using this device to treat psoriasis. Here's some examples. This is just 2 treatments for a patient who had a long history of really psoriasis that has not responded well to topicals or other treatments. And you can see this, again, African-American patient, type 6 skin, dramatic effects with just the Aerolase. Where I probably see this to be the most dramatic difference because of the difficulty in treating with any other modality is palmar-plantar psoriasis. These are 15 treatments. We've had patients who have literally responded to nothing else, did not want to go on oral therapy, have had hand and foot PUVA and other things, and have responded beautifully, as you can see here, to the Aerolase treatment. And in fact, as I said, the clinical impression we have is faster clearance, better tolerated, especially for palmar-plantar disease. And the clinical study that we're in the middle of right now is comparing the eczema and the 1064 Aerolase laser within the same patients for psoriatic plaques on the trunks, limbs, on subjects with mild to moderate psoriasis. So how do I approach a patient with psoriasis? Well, certainly when you see a patient, you assess the patient and determine what's necessary. The treatment options are all discussed: topical and systemic therapies, UV and PUVA, eczema laser, and Aerolase are all discussed. When we discuss Aerolase, we discuss what the laser is, what the treatment is like, what the patients should expect. Almost all cases, when patients are given the choice, they choose the Aerolase over eczema laser in terms of both side effect profile and efficacy. So in my medical record, I document clearly, and this is an example of a summary of the medical record, which talks about the consultation and psoriasis, what it is, what I've explained to the patients, the etiologies, and of course, all the different treatment options, which are listed here: topical corticosteroids, calcipotriene, anthraquinone retinoids, phototherapy, systemic therapies, and laser therapies. And they're all discussed. When I use the Aerolase laser, this is exactly how I document it. Regarding treatment of psoriasis, that treatment options were all discussed. And Aerolase LightPod was discussed extensively. The Aerolase is 1064 short pulse laser, and it is FDA approved for the treatment of psoriasis. Let's make that clear. It is FDA approved. A series of treatment is required to obtain optimal results. Side effects are generally minimal, but can be burning of the skin, hyper and hypopigmentation, which really we haven't seen, but I always put that in there. Eye damage and protection of eye coverings is worn, and we give patients goggles. They can expect a gradual improvement. So this is really how we document it in the chart as well. Now, again, the big question here is, how do you charge for it? Well, the CPT codes essentially say laser treatment for inflammatory skin disease, psoriasis. That's exactly what it says. It doesn't say anything about eczema or anything else. It just says laser treatment for inflammatory skin disease, total area less than 250, between 250 and 500, and over 500. And this is out of the 2018 CPT book. The Miami Medicare allowable is 174.70 for a small area, 191 for 250 to 500, and greater than 500 is $261.33 per treatment. So when you think of this, in most patients who have 5 to 10 treatments, it certainly is significant. The ICD-10 code for psoriasis is L40.0. So overall, the idea of psoriasis and acne therapy with 650 microsecond Aerolase technology is quicker clearance, better patient experience and outcomes, good financial returns, happier patients, and significant safety. And I think that's really the key aspect here. So I will stop there, and myself as well as Julie can answer questions from this, both for the theoretical as well as the practical, how we treat psoriasis patients. And I thank you for your attention.
All right, thank you, Dr. Nestor. Excellent presentation. So again, we will open this up for questions. If you do have any questions, please type them into the question box. I'm going to start off with one that came through here. You talked a lot about the technology. How does this differ than other either pulse dye lasers or long pulse YAG lasers for each of these treatments?
So as I discussed, the key differentiation here is the 650 millisecond pulse. Very, very short pulse duration. And that allows us to get very, very high energies in a short period of time. And as I said, that has some unique characteristics, both from the standpoint of vessels and the standpoint of inflammation, and in the aspect of acne from the standpoint of the sebaceous glands. I have 50 lasers in my office. I have not really had great results with normal long pulse YAG lasers. I've used 1340 for acne for a number of years. I have not had the results that I have with this this technology platform. We did some of the early work with pulse dye laser on psoriasis, and it was effective, but this seems to be much more effective, again, having to do with the wavelength versus pulse dye, allowing greater penetration and the pulse width as well. So clearly there are significant differences because of the unique nature of this, and we've seen that in the clinical outcomes.
All right, thank you for that. What do you recommend as the treatment intervals for both acne and psoriasis?
I'll let Julie take that.
Yes. So typically for an acne patient, we typically treat between 1 to 2 weeks apart per treatment. On the average, we treat about 4 to 5 treatments for an acne patient. For psoriasis, we typically do once a week, and depending on how quickly they clear is how many treatments we do.
All right, and then in that treatment protocol, do you ever utilize any other topicals? Can you recommend any, doing combination therapy for any of these treatments?
So the short answer to that is combination therapy is almost always used initially. And that can really take a number of different combinations. So let's talk about for comedonal and papulopustular acne. Very often we'll use this in combination with a retinoid. And you can choose whatever retinoid you would like, topical retinoid, it works well. For patients with severe acne, very often I will also put them on a short course of oral antibiotics. And that's something that tends to be in combination for clearing for these patients. As you see, I almost never in these patients need to use isotretinoin. When using both topicals and oral antibiotics, they tend to be on them only for a fairly short period of time. Although I will say that for topical combinations, for comedonal and papulopustular, for the comedones, the maintenance with the retinoids tends to work extremely well. For psoriasis, you very well can use combinations with topical cortisones and other topical therapies, vitamin D analogs, etc., very easily in combination with using the laser treatment. Julie, do you have any additional thoughts?
With regards to, well, I wanted to mention that we also, I know we're talking, go ahead.
Yeah, in combination therapy.
Oh, in combination therapy. Yeah, I absolutely agree with what you say, that when we start them off on a topical retinoid along with their treatments, they tend to be on it a lot less time, and they get the clearance with the Aerolase and able to be off medications. So that's definitely a benefit for the patient.
All right. And are there any side effects that you've noted?
Julie, can you take that too?
Side effects with the treatment? No, actually, there's little to no downtime at all. Just a slight pinkness on patients. They just feel a little bit of heat. It's very tolerable, and you know, we definitely. The patients are happy that they're able to go on and leave the office and able to go about their day without any issues, without any downtime, just some very slight pinkness for a short period of time.
And that's very different than what we see very often with the excimer laser, where even if you go up very slowly in terms of the treatment parameters and follow every parameter, patients can very often get burning of the skin.
What does a typical treatment take time-wise? 15 minutes, half hour?
Okay, so for a acne treatment, for full-face acne treatment, basically it takes about, I would say on average, about 20 minutes. We do 3 passes, and then we treat individual lesions as well, individual larger papulopustules. And then for a psoriasis, completely dependent on how large the surface area is, but we do multiple passes as well. And I would say on average, based on the patient's distribution of psoriasis, probably about 15 minutes is rather quick.
And on the photos that you showed, now they were mainly on the face for acne and on the extremities for psoriasis. Are you treating any other areas for either of those conditions?
Absolutely. The back will respond very well, and the chest for acne to the treatments. And for psoriasis, it's really anywhere. Studies include that we're doing now elbows, knees, shins, all areas with psoriasis. And I just showed those pictures because those are probably the most difficult areas to treat with any treatment with psoriasis, the palms and the soles. And we've just had such great results with that.
All right, excellent. So we had another question about some medications for acne, either combining it or do you have to wait with clindamycin or isotretinoin?
So that's good. Clindamycin, absolutely not. You can use it along with it. Isotretinoin, I wouldn't necessarily use it during isotretinoin, but there was recent studies that seem to show that you really don't have to wait very long after isotretinoin for non-ablative lasers, which is certainly what this is. So, you know, again, to help, especially with some of the post-inflammatory erythema that you see in patients after isotretinoin, you know, a very short period of time, a month after, you can treat for that. You're not necessarily treating for the acne because the isotretinoin should have done the job with the sebaceous glands.
Okay. Now, what about other conditions outside of acne and psoriasis? Do you use the laser at all for anything else?
Yes. The beauty of this is that there's a very rich amount of treatment parameters. Certainly, aesthetically, a photorejuvenation type treatment with both pigment and telangiectasias responds extremely well to this device. We use it very often for vessels around the nose, around the eyes, and other areas. We use it for facial rejuvenation as well because it does cause some nice collagen stimulation. There is some early evidence that we can get some skin tightening as well, and we've looked at it from that perspective. There's data on everything from warts to onychomycosis and many, many other conditions that respond also to this technology. Julie, anything to add?
I was going to say I know we focus on acne and psoriasis here, but we very often use it for rosacea in our clinical practice, as well as some lentigines, as Dr. Nestor mentioned, photorejuvenation in combination with pigmented lesions. They get a nice response on clearance from lentigines, and basically just overall the vasculature that coincides with rosacea.
Okay, and we have a number of current customers on the call, and they're basically asking on some of the protocols. Now, are you using the parameters that are recommended in the protocol books?
Absolutely. Once you establish, and that's the beauty about this, it's very easy from a clinical standpoint to use the device. Once the Fitzpatrick skin type is determined, basically you just need to dial up an energy mode. Because of the safety of the device, we can use we can go high up on the spectrum of the energy mode. So once the Fitzpatrick skin type is determined, basically the pulse width is going to be the 0.65 milliseconds, and we just dial up the energy mode that's recommended.
Okay, and so having said that, I mean, how do you determine how to treat a mild acne case versus a severe acne case with the laser?
Well, I mean, we're treating using the same parameters. The only thing that would differ, we're still going to do, for example, acne, we might go towards, especially with the Fitzpatrick 1 through 3, or even 4, we'll go to a higher energy mode. But then after doing 3 full passes of the face, we are targeting the individual lesions with more pulses, and sometimes switching over to a 2 millimeter lens to really target the lesions themselves. So the more inflammatory lesions they have, papular-pustular lesions, even some cysts, we are hitting those after the full 3 passes with multiple extra pulses, anywhere from 3 to 5 to up to 10 pulses per lesion, inflammatory lesion.
All right, excellent. And are there any pearls that you can give that you might have found to be working really well for you guys?
One thing I've noticed from a clinical standpoint on the psoriasis patients is that you want to do multiple passes. We tend to say for acne that we stick to 3 full passes on the face, but for psoriasis, I go by the patient's feedback, especially with these patients that have the thick plaques. I do multiple passes, and I wait for their verbal feedback on, like, okay, now I'm feeling a good amount of heat, and I may move on to another plaque at that point. But very often, we tend to be a little more aggressive with these thicker plaques, and you want to do multiple passes, and they're going to get their clearance even quicker by just letting them decide when, okay, that's enough heat for me. So that's a nice pearl, just to have the patient give you feedback when it comes to a psoriatic plaque.
All right, thanks for that, Julie. All right, one last question that did come up. Coding for acne. Is there any CPT code that you can code for the destruction of acne with laser?
The answer is no. There is no CPT code for acne. Patients are willing to pay. It's especially with what they pay now with copays and other things for their medication and the efficacy, but there are no CPT codes for acne.
All right, so I think with that, if anyone has any other questions, I'll leave it open for about a minute or two, but I just want to obviously respect everyone's time tonight. I want to thank Dr. Nestor for the presentation. Thank Julie for her expertise as well. And would either of you like to add anything else?
No, I think that this is just truly revolutionary technology that if you have a clinical derm practice, the beauty of this is that just the psoriasis alone will not only pay for the device, but have significant revenue. And then everything else in addition to that is gravy. I think one of the beauties of this device is there are no consumables. And I think that's something that is unique in this day and age of lasers and devices. So that really creates a significant financial benefit.